So welcome back. Now I have the good fortune to introduce another great agent of change. Also to many of us, both inside Health Insight and across the country. He's been a teacher to us and a mentor, and certainly a thought leader who regularly challenges conventional thinking. In addition to that, he's just an all-around good guy, and he's always got a great story or two. And so with that, Michael P. Silver.
Thank you. And to begin with, thank you all for coming today. On a bit of a personal note, thank you for what you do. This past year, my family has benefited from the efforts of people like you. People like you have given my daughters more time with their grandmother. And so we appreciate your efforts and what you do in healthcare. So I wanted to start with that. So today, a Learning in Action network meeting. Today is about taking action. At the end of the day, as Deborah explained, we're going to have a session. We're going to have an opportunity to review what we learned together today and how you might or might not apply that in your work. In the meantime, I want you to feel free to explore ideas together. Mark asked for your vision of healthcare, how that's going to look like in the future. Explore those kinds of ideas as with your colleagues and that sort of thing, and then with the idea that we'll commit to some of those at the end of the day. Mark also gave us a sense of the changes that are here and that are coming to healthcare. And I want to focus in this session on the opportunities that creates for us, opportunities to make healthcare even better. As Mark was saying, when we think about drivers of change in healthcare, created by payment and other types of reform, we think that there's a limited ability to really mandate or force innovation and improvement. Rather, much of what reform can do, the important thing it can do, is to create opportunities or to remove barriers to quality and innovation. Of course, removing barriers only matters if there's somebody willing to push beyond and see what's on the other side. What I'm getting at, our goal of better healthcare and healthier communities depends on whether we are prepared to and whether we choose to push those boundaries, find out what's important. And you have a particular role, a particularly important role. People at the front line, people who are close to the front line in any system, in healthcare or any system, have a different perspective. You can see things and opportunities and areas where the system is misaligned that other people can't. Do you have a choice? You have a role and you have a choice here. Mark talked a little bit about some ideas from the Institute for Healthcare Improvement, Don Berwick. They framed much of what we're after here as the triple aim goals. What we're seeking to do and what we have to do is simultaneously improve the health in our community, reduce the healthcare costs, and improve the experience of care. Now, among these three, the first one, improving population health, that's the prince. That's the prime driver here. If you get to that, you start addressing the cost problem in a real way. Moreover, I would argue that the best patient experience is not to get sick in the first place. So, okay. So, and you'll learn more, and I know that many of you are involved in our current programs, but these are some of the ways, some of the metrics that we're using to assess our performance or improvement on toward the triple aim. Among those, we're working in all our states to avoid preventable hospitalizations and unnecessary hospitalizations, reducing readmissions, preventing adverse drug events, depression screening, reducing the inappropriate use of antipsychotic medications in skilled nursing, and improving or increasing mobility in skilled nursing as well. So how are we going to get to those triple aim goals? I'm going to outline or propose some pathways. These are, by the way, not that controversial. There's a great deal of consensus on these as ways to get to the triple aim. First of all, and primarily, preserving and maintaining and restoring health, beginning with the person before they're a patient, healthy behaviors, healthy choices, that sort of thing. And then among people that are patients, are involved in the healthcare system, to promote self-care, active participation in their care plans. Better use of preventive health care, including primary prevention, immunizations, things like that, to keep people from getting sick, but also to support people making healthy choices. And secondary prevention, once people have acquired disease, make sure we use the best evidence and the best care consistently to care for them. And that idea of consistency, reliable, patient-centered, coordinated care. A great deal of the gap we see between where we are and where we'd like to be falls into that lack of coordination. We have all the pieces, we need to put them together. And finally, and we'll talk about this a little bit more this morning, informed health care choices. Patients or those who make decisions on their behalf need to understand the benefits, the risks, and the limitations of the care that they may elect to receive or elect not to receive. Now, clearly, these pathways are going to involve more than just healthcare providers. So, let's see. We have aims. We talked about aims. We talked about pathways, and I want to propose some strategies. Now, we'll be working together in this, as Deborah introduced it, the QIN-QIO. Anybody remember what that stands for? Contract for the next 3.5, almost 4 years. There are going to be additional annual gatherings. We'll be working with you, providing technical assistance, so web-based support, other resources, that sort of thing. And we've identified some change strategies that we want to offer for your consideration. We think that these are high leverage ways to get to those triple aim goals. And they begin with patient engagement. You're not going to get very far on the triple aim on any strategy or any program that doesn't involve patient engagement. So we're seeking to increase the frequency of choices and behaviors that preserve or restore health, increase active participation in ownership of care plans. The process reliability. And by the way, we'll talk a lot more about patient engagement today. There's a session this afternoon. Process reliability means that we have a plan for supporting patients and that we carry it out reliably, consistently. Complex needs. We recognize that this isn't a one-size-fits-all world, and so we have to have the capacity to identify what the true needs are for the patients and tailor the services that we provide to those needs. Health information technology, we'll be talking more about this afternoon, and that supports us not only in patient engagement and in coordination, but actually more especially in coordination as citizens in a healthcare system to share as appropriate the information that we have with others who have legitimate and authorized purposes for that. And then alternate payment. Alternate payment models are going to create and creating right now opportunities for us to better serve or respond to patients' needs. Some useful changes are happening right now, and we need to find ways to take advantage of those. So, and here's the simplified map. Putting this all together, and this tries to indicate some idea of causality, capture that notion that among the aims all the way there on the right are that triple aim, healthier people, lower cost of care, better quality of care, and how those relate to each other. We identify pathways that'll get us there and strategies. So, but what's missing from this map? Well, somebody's going to have to make it happen to execute those changes. And we need change agents. And I guess the cat's out of the bag, my friends. We're counting on you. And we'll talk about why that's a reasonable proposition, or why we hope that you will find that to be a reasonable proposition. We are going to work together. not just for encouragement and not just to share best practices or spread best practices faster, but we need to work together because the problems and the opportunities are bigger than any one of our organizations. To solve these types of problems, we need to collaborate. We will help bring effective change strategies that target high leverage critical functions. So, and together, today and beyond, we will be working together to build capacity to make positive change, to initiate change projects, to make sure that the changes we implement are self-sustaining. So if I haven't made it clear before, if Deborah didn't make it clear, if Mark didn't make it clear, we're looking to you to be the change agents. And you may have been offered similar opportunities in the past. Maybe you don't want to repeat that experience. And you might be asking, or maybe it was a positive experience, but you wouldn't mind it being an even more positive experience. So what's going to be different this time? A couple things. Technical know-how. We will, and we'll talk more about this, but we'll be bringing to the table Health Insight, connecting you with the best thinking in this field of how to make technical changes in healthcare processes and healthcare systems. Health Insight itself has invested almost 20 years of developing capacity and supporting providers making such changes. But also, I want to spend a couple minutes on the second point of change management. Resiliency, building resiliency into our change agents and into our systems, reserves, commitment, persistence when setbacks are encountered, and overcoming resistance. In order to pursue an ambitious program like we're talking about, we have to have the reserves to begin something new and hard and potentially hard and to stick with it. I want to include or show you a video. I think I know how to do that. We'll see if this works. Oops, it didn't work. Hang on just a moment.
Hi, my name is Brian Sexton, and today I'm going to share with you the 3 Good Things intervention. It's a resilience exercise. It's our most popular resilience activity that we offer at the Duke Patient Safety Center. Let me talk a little bit about where this came from in this brief video. We know in healthcare right now, if you look across different professions, whether it's perfusionists, surgeons, nurses, administrators, people work in IT, administrative support, about 1 out of 3 folks who work in healthcare today meet the criteria for not mild, not moderate, but severe emotional exhaustion, otherwise known as burnout. So it's 1 out of 3. You look left, you look right, you look in the mirror, one of them is burned out. In primary care, it's over half. In emergency medicine, it's over 60% of them meets the diagnostic criteria for burnout. So it's a pretty significant issue in our industry. And one of the easiest, lowest hanging fruits, low cost to no cost intervention to work on this, from our perspective at the Patient Safety Center, is the 3 Good Things intervention. What is 3 Good Things? In a nutshell, the efficacy of 3 Good Things trends better than Prozac, but we'll talk about that here in a second. Where did it come from? Marty Seligman was the president of the American Psychological Association for 9 years. He's a clinical psychologist. He founded the field of positive psychology. He created the 3 Good Things originally as a gratitude journal where each night before you go to bed, you write down 3 things that went well that day right before your head hits the pillow. He covers this and other positive psychology interventions in his book Flourish, A Visionary New Understanding of Happiness and Well-Being. Let me break down 3 good things for you in a nutshell. Barbara Fredrickson's a psychologist who says the negative screams at you, but the positive only whispers. If you've ever noticed that it's hard to remember a good joke, then you understand that the positive only whispers. You will eventually be in your late 80s with full-bore dementia. You won't be able to recognize your own children in a police lineup, but if you hear a rattlesnake rattle, you'll think, oh, snap, that's bad, right? What is that? That's bad. I know that's bad, right? Because the negative stays with you. We are hardwired as human beings to remember the negative, to reflect on the negative, to notice and recall details from the negative. So the negative screams at you, but the positive only whispers. And we have a strong negativity bias as human beings. This is part of what feeds in to burnout, because it's easier to remember the heart-breaking moments at work every day than to remember the heart-warming moments. And every day there's a little bit of both, but we're tuned into explicitly the heart-breaking moments. So if we can remember, number one, we're hardwired to remember the negative. The second point we need to make from this is that we have enhanced recall of material that we learn or review or reflect upon during our last 2 wakeful hours. So what's the best time to study for boards? Not 10 a.m., 10 p.m. What's the best time to reflect on what's gone well today? Not at lunchtime. It's right before your head hits the pillow, as close to sleep onset as possible. Now, what you do during your last 2 wakeful hours is what you're going to recall in your dreams, and you're going to recall that information more accurately and for a longer term. So whether or not you're reading mom porn like Shades of Grey or playing Angry Birds on an iPad, that's what kind of sticks with you as you're going off into dreamland. Why not spend that time reflecting very briefly on what are 3 things that went well today and what was my role in bringing that about? Because the efficacy of this intervention is just so very powerful and impressive. So number 2, we remember things during the last 2 wakeful hours. So you want to do 3 good things as close as possible to bedtime. You should do it practically when you're in bed. Number 3, with practice, by day 4 or day 5 of doing 3 good things, you actually are going through your day noticing more positive things. Your heartwarming moments-ometer is finely tuned. You're catching them. You're noticing them more well. And saying, I can put this in my log tonight, because you've actually flexed the muscle and enhanced your ability to take in those positive moments. So by day 4 or day 5, you're actually noticing more positive. Not that more positive is happening, but that the positive that is out there is making it more readily onto your radar screen. This has been published. The original randomized clinical trial was demonstrated by Marty Seligman and his colleagues, where they demonstrated this in nicely controlled, kind of empirically rigorous conditions, and showed that 3 good things actually trends slightly better than Prozac and other SSRIs. Selective serotonin reuptake inhibitors work really well for people with severe depression, people with mild or moderate depression. They are actually no better than a placebo or a sugar pill. So the great thing about 3 good things is it works for severe, mild, moderate. It also works for people who have no depression at all. It actually enhances your happiness and helps you with work-life balance and reduces your burnout. So it works beyond just the traditional variables of happiness and depression. What's interesting here is in the original study that Marty Seligman published with his colleagues, if you look at 6 months post, if you look 6 months after having done this intervention, it looks like you're still on Prozac, even though you only did it for a week. We now know you should do 3 good things for 2 weeks, because you can make the effects of the intervention last longer by doing it for 2 full weeks. And we've got some tricks to help you kind of stick with it for the full 2 weeks. How do we do that? If you register with one of our 3 Good Things cohorts, the DukePatientSafetyCenter.com, www.DukePatientSafetyCenter.com, you can actually, you give us your email, we will give you an informed consent. If you agree to participate in the research, we will send you an email at 7 p.m. Eastern Standard Time that looks like this. Please follow this link to go to your 3 Good Things log for today. The next thing that comes up, if you press next, is would you like to share or not share your 3 good things? We do this because some people say things like, oh, today I took the stairs instead of the elevator. I'm trying to take care of myself, or I stuck to my diet. Other people say things like, oh, I asked for sex with my spouse tonight. I got it. Yeehaw. I'm so happy. You can see where some things you might want to share publicly, where other people can read it, other things you want to keep private. Let's say that you hit share. And by the way, 3 Good Things works whether or not you share, which is really cool. We haven't published that yet, but the effect is the same whether or not you share. And there are a lot of people who don't share who are voyeurs and go read all the comments of people who do share. That's okay. You're welcome to do it. You get an email like this. If you click on the link, you go to 3 Good Things, number 1, number 2, number 3, and then we have another activity. So you enter what went well today and what was your role in making it happen. And then we ask you to select from a pull-down menu, what is the positive emotion that best fits how this good thing made you feel. Now, you can fill this in. My 5-year-old swam across the pool at the YMCA today without any floaties for the first time. I'm so proud of her. What was the positive emotion? Pride. Good thing number 2, I watched a glorious pink and orange sunset behind rolling hills where the leaves are changing with these fall colors. It was just beautiful. What was your positive emotion? Awe and wonder. So you select that. You get to savor your 3 good thing entry from earlier today just by thinking, what was the emotion? That's what it was. It's kind of a nice little, it just takes a few seconds to do it, and it actually enhances the effect of 3 good things. Good thing number 3, I made my wife laugh today so hard that her eyes watered, and so did mine. You could put that under amusement. You might put that under love. You pick an emotion to go with it. When you're done, you hit submit. You're redirected automatically to a log of all the good things that were entered by participants the previous day. So you can see how other people use it. And seeing how other people use 3 good things can be very helpful and inspiring. It can keep you kind of on the path of doing it. The email reminders help. The ability to see how others use it helps to keep you doing it. The very first time we did this in the neonatal ICU, we actually found that these are word clouds on day 1 versus day 14 of 3 good things. They're talking less about work, less about time, more about family, more about home, more about husband. You can see that they're moving in the direction of more work-life balance. And the great thing about this was the first time we did it, we saw an increase in happiness and a decrease in burnout. So just the same effect. We started adding more variables to the cohorts. We did this next with our Duke internal medicine residents, found some very impressive results about not just burnout and depression and happiness, but also work-life balance. Essentially, these residents, these internal medicine residents, we announced 3 good things at noon conference. We had them register during noon conference for the study if they wanted, and then every day for the next 2 weeks, they got a 7 p.m. email from us that said, what were your 3 good things? And they entered it. We found lower burnout, lower depression in the post. They experienced fewer delays. They had less conflict with colleagues, fewer disruptive behaviors, and better work-life balance. They got home on time more often. They skipped fewer meals. They ate fewer kind of poorly balanced meals, and they reported better sleep quality. All of this is really good for your work-life balance. The greatest thing about this, too, is that the residents really enjoyed participating in the research. And when they were done, they're like, hey, I kind of like that 3 good things thing. What else you got? You got some more stuff like that? That was very encouraging. If you look across the Duke University Health System, these are 258 bars, 258 clinical areas and work settings across my health system, where you can see the percent of people reporting resilience. This is the percent of people, each bar is the percent of people who do not have any burnout, not mild, not moderate, not severe, not at all burnout. And it ranges from 10% to 70, 80% or more reporting burnout. When you look at internal medicine residents at Duke in the pre versus the post, they climbed up a quarter of the distribution in 2 weeks of doing 3 good things. We replicated this again when we did this with our patient safety leaders and mid-level leadership across the Duke University Health System, found even stronger effects as we start to kind of tighten up our methods and make this even more convenient, more accessible. These patient safety leaders across our health system went from kind of the mid-range of the distribution. They jumped up like a third of the distribution in just 2 short weeks. These are supervisors, managers, directors, medical directors, even senior leaders, vice presidents, etc. We found that 95% of these folks at the end of the study would recommend 3 good things to a friend or to a supervisor. So this is easy to do. It's fun to do. It doesn't take a lot of time, and it's easy to kind of encourage your kids, your spouse, other colleagues to participate along in it with you. In our patient safety leader cohort at Duke University Health System, we found significantly lower burnout, lower depression, higher happiness, better work-life balance, improved sleep quality, and there was a trend toward more sleep, but it wasn't statistically significant. But there was a big improvement in sleep quality, which is fantastic. 98% of our participants complete 3 good things within 3 minutes of starting it. We get that from the timestamps. So it doesn't take a lot of time to do it. It's relatively easy. It's relatively low cost. If you go to Duke Patient Safety Center website, www.dukepatientsafetycenter.com, and register with whatever cohort we have available for you on the website when you're viewing this video. I encourage you to take advantage of this.
I will finish this for him, I think.
Hi, my name is Brian Sexton, and today I'm going to share with you the 3 good things intervention. It's a resilience exercise. It's our most popular resilience activity that we offer at the Duke Patient Safety Center.
I think he started again.
A little bit about where this came from. Hi, my name is Brian Sexton, and today I'm going to share with you the 3 good things.
This is going to come back. In your workbook, there's Brian, take it easy.
At the Duke
In your workbook, there's some information links. We have made arrangements. If you are interested, you or to have your organization are interested in participating in this intervention, we've made arrangements for you to do so.
Hi, my name is Brian Sexton, and today I'm going to share with you.
We made arrangements for you to do so,
resilience activity that we offer.
Sorry, the information is in your workbook. There it goes. See, I didn't do it hard enough. I tell people you push those buttons harder, and good things will happen. So, if you're interested in this, and I recommend it, I just went through it myself. Brian reviewed the science behind it. This is solid stuff. If you do sign up, please select Health Insight Change Agents, and then we'll be able to report back to this group your results. We won't know any. This is all confidential, of course, that sort of thing. We have. Oh, there we go. How about a quick poll? Again, the same methods, text or on email or the website or whatever you do with that. Is burnout a problem where you work? 3 choices. 1, burnout is not a problem at all. Minor and occasional problem. Burnout is a significant problem. We have a little bit into your responses. We got responses coming in? No? Nothing? Oh, yeah. People just don't care enough to. Okay. Oh, look at that. Okay. All right. Oh, wow, we got a lot of people weighed in, and we have a lot of people telling us burnout is a significant problem. This is worth addressing. It's worth looking into. In fact, what I want to do, I'm interested in that result. What I want to do is again, this is a workbook activity. I'm trying to. Oh, there we go. This is in your workbook, and it was one of my jobs to look up the page number, but I didn't do it. So it's on page number 2. Thank you. I'd like you to spend a couple of minutes. Why don't you go through a quick 3 good things inventory that's in the workbook, and then share your findings, share your 3 good things with people around you, and take a minute to talk about how could you promote the use of the resiliency tools or the 3 good things exercise where you work. We will take 5 minutes on that, so we'll reconvene as a group at 47 minutes after the hour. So I'll give you 5 minutes. 3 good things. Talk to your colleagues. How else could you use this?
Sunday,
All right, we best reconvene here, here and everywhere we are. Sorry, thank you. All those good things. I know we want to share. We don't want to stop. In fact, it's a very good thing. We need to do more of that. Sorry, we have to. Sorry, thank you. To reconvene. So just, Wyatt was telling me the final count on the polling, it looks like about 40% of the respondents and over 300 respondents said that burnout was a significant problem where they work. Now that's an important outcome in its own right. But we're going to be talking about patient-centered care. And I would assert that if that's what we have, if that's the raw material that we have to work with, people that are burned out, we won't be producing patient-centered care. It won't happen. Those things are incompatible. So I would recommend and hope that you take advantage of the resiliency training, and we will bring more to that sort of thing to you if you're interested. So just a couple notes. One is, again, we're delayed. Maybe you got the slides. I'll tell you about Health Insight Accountability. What can you expect from us? We're going to be creating learning opportunities, forums where you can connect with colleagues and other change agents seeking to make healthcare better. We are connected to, through in the country and through other innovations efforts, what we think of as the best thinking in this field, and we'll seek to bring that to you. And then we'll actively support you through data and technical assistance, that sort of thing. That's our accountability. That's what you can expect from Health Insight. What we have a request from you. As we said, we're looking forward to the end of the day. This is about an action plan. So we're going to ask you this afternoon to develop a plan, something that you can commit to, even if it's only to tell people back in your organization about 3 good things that maybe they'll benefit from it, but you may push yourself beyond that. But until then, I want to ask you that you'll consider possibilities, including the possibility that together we can make a difference. One of the characteristics of a change agent is they know the difference between saying it's impossible and it can't be done and saying, I don't know how to do it. One of those things closes a door, and the other one is a starting place. And I think we're better served by that starting place perspective. So that's what, and you'll just have to be inspired by my words and not by my slides, because they're not keeping up with us here. So, and that takes us to the end of this session, and thank you so much. Deborah's going to introduce our next speakers, and we will actually catch up the slides. I'm sure I broke something. So.
I think you did break something. Well, the good news is our next speakers don't have slides, right? So it's my pleasure to introduce our next 2 speakers. They are affiliated with the Nathan Adelson Hospice here in Las Vegas, which was founded about 30 years ago or so. Nathan Adelson is the only nonprofit hospice in Southern Nevada and provides hospice and palliative care to over 350 patients every day. I'm pleased to say that they took such loving and wonderful care of my father and me and my mom for a good while, and we sure appreciate that very, very much. Nora Lunda, our first guest, is the Director of Diversity and Education at the hospice. And in 2013, she was the recipient of the Vegas Inc. Women to Watch Award. I think that sounds like change agent. I don't know. I think there's potential there, Nora. That sounds like that to me. Also, we're welcoming Laura Coleman, and Laura has been affiliated with the hospice for the last 23 years or so. She's had several family members cared for by their staff, and also has been a very active volunteer at the hospice as well. She's also very active in the community for many, many years and in numerous capacities. A woman, I think, who truly makes a difference. Please help me welcome Nora and Laura.
Good morning, everyone. I'm going to just tell you briefly about 1 minute about our new initiative called Deciding Tomorrow Today. You all should have a copy of this that is hot off the presses. It was actually delivered here this morning. Being in hospice, we see every day the results of what happens when people have had discussions about what they would want at end of life with their family members, when they've thought about what they would want, when they've written it down, when they've, explored the options about what their values are, what their priorities are, what quality of life is. We see how things go a lot more smoothly at end of life, how families are focused on caring for each other, on fulfilling their loved ones' wishes. And we also see the opposite when people haven't had those conversations, just how hard it is. Families disagree, brothers and sisters stop talking to each other over their disagreements about, what mom or dad or the brother or sister, what they would want or what they said to one family member or another. And so we really feel that people should think about it, consider it, write it down, have these conversations. So we are launching our Deciding Tomorrow Today initiative, which is about helping people have those conversations, toolkits, conversation starters. And the first thing in any of all that category is our guide for providers. That helps people have the conversation, helps healthcare providers how to, start that conversation with their patients and family members. There's a guide for providers on talking to patients who have terminal illness and tips and things like that. So our website is not up yet. It will be very soon, decidingtomorrowtoday.org, and there'll be downloadable tools and things like that. So we hope that that is a helpful tool for you all. And Laura Coleman has been a volunteer with Nathan Adelson Hospice for many, many years, and she has personal experience with this and that she's going to share with you. Thank you.
Okay. This is my mom. Okay. I'm going to put my mom right there. She's always kind of crooked anyway. Okay. Well, not like crooked in a bad way. Okay. And this is my mom's story. And I'm going to start with this envelope right here. And this envelope says, "Please open in the event of my terminal illness or sudden death. Evelyn Newman." And inside there's a piece of paper, notebook paper, and it says, "This is to certify that in the event of my having an irreversible illness, there shall be no life-prolonging mechanisms attached to my person or administered to my system. In other words, let me die with dignity. Thank you. Evelyn Newman, 7/29/80. And I've written down what I'm going to say to you, because I have a tendency to wander, and I want to make sure that I get my mom's story across to you. Okay, so that was written in 1980. So we're going to back up to October 8th, 1978. My father had open heart surgery. It didn't go as it should. And from October 8th to 1978 to February 8th, 1979, my father never left the hospital. He lay comatose, hooked up to wires, in intensive care, with no hope, no information. Day after day, my mother sat in the waiting room. 5 months, only the words, no change, no compassion. On a side note, that day, October 8th, 1978, my daughter was hit by a truck, and she was laying in another hospital here in Las Vegas, and she was dying as well, but she did come through. A year passes. My mom, at the age of 66, just 3 years older than I am now, sits down and writes that paragraph. She was healthy at the time. 1984, my mom's leg hurts, up by her hip. She rubs it constantly. She goes to the doctor, a doctor who was a friend of hers, but a doctor, and the doctor says, "Oh, Evelyn, you're just getting old." Really, that's what the doctor said, because I was there. She and I take a trip to Switzerland. She has good days and bad days. We spend New Year's Eve, 1984, in Switzerland together. The trip home takes a toll on her. Her leg still hurts. January 1985, we go to the doctor. He sits across from her and simply says, "You have cancer in your femur," hence the leg pain. She heads down to San Diego to have her femur operated on, and while she's there, someone breaks into her home and steals everything she owns. But that's a whole nother story. Coincidentally, in this thing is also at the same time, she wrote down everything she owned at that time and who gets what. And guess what? That doesn't happen because it's all gone. Okay. She does her rounds of radiation and chemotherapy. They don't make her feel better. They just make her sicker. I'm the youngest of 9 kids. My mom goes to Virginia to spend time with my sister Jessie and her family, and my oldest brother Mike and his family. Ultimately, she wants to come back to Las Vegas. This has been her home for many years, and this is where I am and her favorite granddaughter, my daughter Jessica, are. Chemo and radiation aren't keeping her pain-free. She has a lot of pain. The doctor recommends hospice. At the time, Nathan Adelson Hospice was only one of 2 in the entire country. There wasn't much known about it. What I did know is that we're very modest people. And with the promise of a volunteer coming to our home on a regular basis to bathe my mom and look after those kind of needs, and the opportunity to have morphine administered to her to keep her pain-free, I hadn't read my mother's words yet. I didn't know until after she died, but what hospice promised was clear. The end of life journey was her end of journey in life was free of pain and with dignity. My mom was an incredibly dignified woman. She deserved that, and she got that. After 26 years as a volunteer with Nathan Adelson Hospice, I've seen something different, though. I've seen family members who don't agree on placing their loved ones in the hands of hospice simply because they're going on information that was relayed to them from a confused family member. Rather than realizing that death is right around the corner and making the time they can with the family members quality time, they're scrambling to find cures that don't exist and fighting over what's best for mom. I recognize that often when patients are older and the two people who are sitting with the doctor learning of the diagnosis, that the sick one and the spouse is there, the diagnosis is overwhelming, and sometimes they're only basically catching every other word, so it becomes a not fun game of, the orange juice can and the words just don't get through. And my hope for healthcare professionals is that it gets back to the day of the old-time country doctors, that every part of this end-of-life journey matters. And for me, taking the time with the family, not just, I have to tell you, and this probably is politically incorrect, but I hate HIPAA laws. I hate HIPAA laws. And I'll tell you, because when someone's sick, it belongs to the whole family, not just to the one person sitting there that's translating all of the doctor said this and the doctor said that, and then those family members are all, half of them are left in the dark. And hence, as the time grows nearer to the end of life, everybody's wanting to do something different. I really wish that doctors and all of that are concerned would gather and really, really talk to them about getting all the family members in that room and talking about what's going to happen in the next few weeks, in the next few months, however long it's going to be with the entire family members, because it's only fair, it's only right, because that's such a precious, precious time. And so often it's just that one person relaying the message to one another. And I look back on my mom and having 8 brothers and sisters and being the youngest and sort of kind of being in charge of everything. And I don't know why, but there was so much that needed to be shared with everyone. And if we all could have been in the room at the same time when that diagnosis came, it would have been so much clearer. And that end of life time for my mom, through Nathan Adelson Hospice, they knew the right thing to do. And I have to tell you, and I have a friend whose father died recently, maybe 3 years ago at hospice, and they had not had the end of life talk. And I sat there with my friend in the hospital room, and she was shocked that her father died. After 5 years with Alzheimer's and many, many, many other things going on, she was shocked. And I sat there after her father died, calling funeral homes, calling this, doing that, getting pricing. And she was arguing with her sister, and her sister didn't know how this happened. And I guess as the voice, and it says on your thing that it's the voice of a patient. The voice of the patient, let me tell you, my mom, Evelyn Newman, who was the smartest woman I know, ever knew. She never had a mother. Her mother died when she was an infant, and she was pretty much just raised on the streets of New York. And here she had these 9 children. But what she did, this gift of writing these words down so that when it was done and when it got down to it, we knew what to do. And it wasn't hook mom up to this. It was clear. And back then, think of that, back then in 1986, she wasn't talking hospice. She didn't say put me in hospice, but she was saying, let me die with dignity. Please let me die with dignity. And I just encourage anybody out there to please, as healthcare professionals, consider the entire family. Throw HIPAA out the door. And just let everybody that's concerned give that patient that time to be with their loved ones at the end so they can take that quality of time. Thank you.
Did you get Mom? Oh, okay. Thank you, Nora, about telling us about the wonderful program that's beginning at Nathan Adelson, and also for Laura for sharing the story about your mother who had such insight and to share her wishes with you, and for you all to comply with those wishes as well. So thank you for sharing that. Wyatt, I'm wondering if we have any comments related to what Laura had to say, or any questions along those lines yet? No? Okay. How about anything else that we want to cover? We do have a little time. We might even be able to go back to Mark or Mike if there's other thoughts that we wanted to mention. I'll give you just a moment. I kind of caught you off guard there.
Yeah, Deborah, we actually did have a comment during Mike's section. This is Laura commenting, we need to be more invested in learning about patient engagement from the patients instead of assuming we know how to do it. Great comment and perspective as we just learned from Laura.
Right. Well, and thank you. You know, a lot of times it's like, oh, well, we're all patients, or we'll know how they would like the lounge set up, or we'll know. And it's like, oh, well, I guess we could ask them, that we build these things for. So I think that's, it's kind of that paternalistic approach that often we've grown up with in healthcare, I think.
Another comment, Deborah, that came in through our web form, and this refers to a comment that Mike made. I challenge, it is not about the patient, it is about the person before they become a patient. I think that actually went back to Mark's first point about patient needs to be the center of our system. This individual feels like it needs to be the person before they become a patient.
Yep. And I think Mike alluded to that as well, about if we keep healthy and don't become patients, then that's really what the ultimate goal is there, I think.
And Deborah, one more comment
okay.
Relative to Nora and Laura's presentation. Catherine comments, very timely information. I am planning on chatting with my own parents about this over Christmas break. The only time I can round up everyone and have their attention. Cookies and hot cocoa to sweeten the deal.
It sounds like a nice plan. I know some families do that over Thanksgiving or other kind of holiday times when you are all together and you're feeling thankful for each other. And I think it's a real gift that we can give each other so that people know what you want. Mike?
They don't request comments, that sort of thing. What opportunities are there? We had a challenge from Nora that how can we initiate those conversations as providers?
Okay, so Mike just challenged us to chat in. How can we provide for those opportunities as providers? What and how can we create opportunities to have those conversations with our patients? And, we also have families too. So how can we do that even with our families? What is it that we can do? How do we create those opportunities? There's a number of references. I think Nathan Adelson's will be great. There's one the conversation or start the conversation, something like that. I don't know if others have, is there any other comments that Laura or Nora would want to make? Sure, come on up. Nora's going to join us here. Thank you.
Yeah, you're right. There are many resources that exist that are good, that provide good toolkits. One of them is called Consider the Conversation, I think is the one that you mentioned, the Conversation Project. There's another one called Death Dinners. The person who wrote in about having that conversation over Thanksgiving, they have some really good tools on their website, Death Dinners. They have websites. Our CEO actually participated in one, and she was filmed by a news station doing that. and it was the whole family getting together. They try to make it a little bit light so it doesn't seem like, okay, we're going to have this conversation about, and so, they provide ways to start. They have things that you can use when you see things on the news, or, everybody's experienced family members or friends that things happen and maybe things don't go as planned. And obviously people get resistant sometimes, like, no, we don't need to talk about that now, or you're totally fine, let's not talk about that. And so sometimes we have to, kind of push back a little bit and say, yeah, this is why this is the great time to talk. When I first started working at hospice and learned about this, I actually did go to my parents right away and say, oh, you really have to fill out your advance directives. I want to know in case anything happens. And they said, well, what are you talking about? We're totally healthy. Are you trying to kill us now or what? And, if anything happens to me, just shoot me. I'm like, no, that's not a plan. That's illegal. And you're not writing that down. So, I couldn't get them to fill out their advance directives, but I actually did mine, and we were using the 5 wishes. That's another tool. Aging with Dignity is the name of that organization. The person that started that used to work with Mother Teresa. So that's called the 5 wishes, Aging with Dignity. And so I completed my 5 wishes and, sat down with my parents to talk to them about it. And then they thought it was great, and they wanted their own, and now they've done theirs, and they constantly ask to borrow, or to have more of those forms so they can give it to their friends and family. Those are available in like 30 different languages. And that one specifically is written in a very simple, like not so legalese language, yet of course it's a legal document. So those are some other tools. There's someone who has their hand. Okay. The 5 Wishes is its own organization, and you can purchase them. They're $1 each, and you can purchase them from them directly. With our Deciding Tomorrow Today campaign, it's a similar concept in terms of providing tools and forms that people can fill out. Those will be available on our website.
Thank you, Nora. That's really helpful. You can go in and chat your questions, and Wyatt does have a couple of comments and a couple of things that he's going to bring forward. But in the meantime, go ahead and chat in. That's the easiest way for us to talk about those. Wyatt?
Yes, a comment from Barbara. My daughter's 24, and due to the work I do, we always have medical, durable power of attorney in place and 5 wishes completed. This keeps families from burdening with guilt and guessing at a time of crisis. It is never too early to have these conversations with our families. Another comment, Deborah, from Catherine. Sometimes providers see multiple members of a family when one passes away, asking how the surviving are doing and asking how the experience was. Then ask if they have their wishes written down. Give a resource toolkit online to help get them started.
So when somebody does pass, it's an opportunity, if you haven't already, to go ahead and complete those things or think about those conversations.
Another comment from Daryl. Great book about this very subject, available on Amazon. The Sandbox Wars, End-of-Life Decisions, the Most Important Gift to Your Family. Too many comments coming in. I just lost it. By Stephanie Payne, author.
He's reading as fast as he can.
Discussion of the POLST form, Physician Orders for Life-Sustaining Treatment form, is another way providers can broach the subject with patients and families. Go to, this was for an Oregon chat, or or.polst.org. I'm sure there are similar in each of our locations.
Okay. I know when I first sat down with a friend of mine and my husband to talk about what we wanted, or mostly it's what seems like it's what you don't want. And as I was just looking at the guide that you handed out, and you say, well, I don't want to suffer. And then you take another, like, well, what does suffering mean to you? I mean, because it could be different than that. And so it's not really like something that you just do at the spur of the moment, I don't think, or, quickly like that. I mean, it really is thought and really does make you think in a different way about what you do want, and how you want to share that with others as well. And I do know a lot of our staff have been very active with helping nursing facilities in Nevada fill out and providers understand the PULSE, which is an actual order set so there's an order from the physician that is carried out at you have to be, like, I think, terminal and within 6 months of dying or something like that. So the advanced directive is, for anybody at any age and that sort of thing. And as you mentioned, they have them in Oregon, and I know Utah, and like you said, probably New Mexico as well. You have another point?
Yes, actually a question and an answer.
Okay.
A question from Patricia. How can these discussions be incorporated into primary care? Needs to be reimbursed. And covertly, Mike Silver slipped me a note where he referred to, this was before the question came in, that the annual wellness visit through Medicare is a reimbursable visit that includes end-of-life planning as part of that visit and assessment with their Medicare patients.
So I think that's really helpful for people to know that the doctor is compensated. And sometimes, it's not that comfortable for the doctor to bringing it up too. I mean, I know for my father, he had the physician, I don't think he ever would have brought it up, but he had sort of a temporary physician that was working with him, and she took care of Dad for a while, and we were just going to the hospital all the time. And she's like, have you ever thought about hospice? And like, yeah. And I tell you, we never went back to the hospital again, and he would do really, really well, and then he would do not very well. But it was, really that love and support that it really did. It made all the difference. And it was as good as it could have been that way. And it was at home. It was at home, so that was beautiful. Okay.
A couple of additional resources referred to from New Mexico. The great resources for families in medical crisis to facilitate communication, www.caringbridge.org. Also, the National Pulse is available at www.polstpulse.org.
Okay. Very good. Very good. Well, thank you all for sharing all those resources and your stories. Laura, we thank you so much for that. And your mother would be very proud of how you've carried on for her. So that said, we're a little ahead of schedule, but we're going to go ahead and wrap up here. How about if we have another round of applause for our great speakers this morning? So some of the highlights, and again, this is a place where you can chat in. What are some of your takeaways? What are some of the highlights from the experience you've had this morning? You can also tweet those, certainly. I think Mark gave us a great overview of the impact of the cost of healthcare and what that really does, what that means. The thing that hit me there was it takes our pay raises. Wait a minute. It gives me a good raise and off it goes. I don't really get it after all. It just seems like that. I also thinking about joy in the workplace, and kind of that links very well to Mike's talking about burnout and the role of resilience. I've been a nurse a long time, and I know when I work now with people in nursing facilities or hospitals or other settings, it's really not what most of us had in mind when we first decided to go to school to do this. It's a heavy weight, all that paperwork and the computers and, all the changes and HIPAA and all the different things. It's easy to get burned out. It's easy to get burned out and not feel that joy. I was really excited. I had heard about the, 3 good things before. We've done that, a couple of times, but I had never, I thought Brian did a great job of talking about really the science and the research and the study at Duke. That's no small potatoes there. It seems like the real deal. And really the impact of just saying 3 good things every day before you go to bed. That's pretty remarkable. And that we have an opportunity to participate in something like that too, nationally, be part of that research. So that's one thing I'm gonna do. I think that's and I think we could do that, in the workplace to remind each other to do that. I can send an email. We send emails for other things at 8:00 at night at Health Insights, so we could probably do that's sort of an inside joke there. Let's see. The importance of the patient's voice. Again, thanks to to Laura for sharing her very personal story with us, and for Nora to sharing the great work that they're doing at Nathan Adelson. There's great hospices in all of our states and across the country, and they're a real resource to us, and I know they're happy to come and talk about their programs and to your organization if you want to know more about how you can get involved in that sort of thing. We like stories, and I could relate to Mark's mother-in-law, and I love and her iPhone and the what she pasted on the back of it, and I think a lot of staff would understand that I could relate to that story very well. So I thank you for sharing that. Again, why don't you go ahead and chat in your thoughts of what you're going to be taking away, and we'll have Wyatt in a moment kind of look at that and share those things with us. Again, you can't get away from this word, and that's action. That's what we want you to be thinking about as we move into the afternoon. And just, kind of think about, you've got your workbooks there or your note cards, whatever, what kind of ideas for change have come into your mind? Did you talk to somebody, or did you hear something in the chat? Did somebody mention something that said, oh, I never thought of that. That might be something that I could do. Did you learn something from somebody that you spoke to? I'm sure that you did. Did you learn something from going to the poster gallery maybe? Did you say, anything that made you say, something you'll do differently? And then again, you've had the opportunity to be with us, but what are you going to do when you go back to your organization? How are you going to share what you've learned? You can certainly share 3 good things, but there's a lot of work here and there's a lot of good information here. So how are you going to share that? As part of the network. Remember, we're creating that network among us. So again, jot it down, talk with people over the break, and think about what you're planning to do. Oops, I went back too far. Sorry. So evaluations. Time flies, right? It was just early morning, and now it is time to do the evaluation. So again, we have a couple different ways for you to do that. So you can scan the QR code out of your workbook on the cube. You can also go to this web address if you'd like to do it electronically by going that route. For those of you that are in person, there's a hard copy evaluation on your table. And so we really do appreciate if you take some time to fill that out. And there'll be a designated place in each of your conference rooms where you can leave those with us. And let's see. I guess you can also click the evaluation link in the chat, in your chat box there, and you can do it that way. So a lot of different opportunities. We really do, this was a first of a kind event with a lot of different sort of moving parts. So we're interested, how did that work? Was it disruptive? Did you feel involved if you were online, that sort of thing? Because that's really our goal. Like we said, we're going to do mini lands over the quarterly, and then we'll come back every year for another session sort of like this. But based on your evaluations, it could be quite similar to this, or it could be quite dissimilar, depending on what you think worked well and what didn't work so well. So we really do appreciate your taking that time to think about it and actually even write words. You probably have a chance to circle some numbers, but words help us even more than the numbers do. So that said, again, we're a little ahead of schedule here. The bottom of the hour, we're going to take a break for about an hour. And people on site, your local host, is going to have some instructions for you about what happens during the break and what happens after the break. So we'll stay tuned for that. And those online, after we hear from some final words from Wyatt, you're going to be disconnecting from us and then reconnecting for the afternoon sessions. And I'll tell you about that in just a moment. Let's go to some final good words from Wyatt and all of you.
Not much coming in, Deborah, after our previous discussions, just some more comments about patient engagement, that they'd like to hear more about the social determinants of healthcare.
Okay.
That needs to be front and center in our discussions with patients. And again, some pleas for reimbursement of providers to help support this type of true engagement.
Okay. Well, and I think, Mark talked about incentives, their roles, and talked about payment reform, and I think that will help us to reach those kinds of goals. And so I think people that are concerned about that are going to see big change in that area as well. So, well, with that said, what's next, as I promised, is a break. And so you will have time, if you're in the room, to do some networking. For those that will be leaving us now, you can disconnect. We want to thank you so much. It's generally a disadvantage not to be in the room with others, but we hope we've created some opportunities for you to feel like you're connected to us. We're going to, like I said, take an hour's break, and then we're going to ask you online participants to reconnect by selecting the first breakout session that you want to attend. There are 3 breakout sessions, and again, you can do it on screen, or here's the website. So if you're online, you can choose your and connect to your breakout session that way. The breakout sessions, there's one on health information technology, there's one on patient engagement, and there's one on process reliability. So again, pick which one you want to do first. This afternoon those will be hour-long sessions. We'll have a 15-minute break, and then you'll be able to choose a second session to participate in. So that said, we will see you in about an hour. Folks online, it's been great having you. Thank you so very much for your patience and for being with us. And if not before, we'll see you probably around this time next year. So thank you so very much. Have a good afternoon.